Hello and welcome everybody. Thank you for joining us for our first in a series of webinars that we're doing, aiming us to get ready for to respond to the SCPHN standards consultation. We're recording this webinar, so just to say that if you want to ask a question and you don't want your name being recorded, then please ask your question anonymously when we get to that point. My name's Jane Beach. I'm the lead professional officer for regulation with Unite, and obviously work closely with CPHVA. And I've been a member of the NMC post-registration standards group, so working on the standards from the beginning. We're focusing on SCPHN standards this evening, so we're not looking at SPQs, so hopefully that's okay for those of you that are joining us. I'm joined this evening by Amanda. If you could introduce yourself, Amanda.
Thank you, Jane. Yes, good evening, everybody, and thank you for joining. Lovely to see so many already have joined. So my name is Amanda Holland. I am a lecturer at Cardiff University, and I'm the programme manager of the Specialist Community Public Health Nursing Programme at the School of Healthcare Sciences. My other role, for which I'm here today, is I represent the CPHVA in Wales as Wales's chair. I am also lead for regulation with the CPHVA, and I've been very fortunate to be part of the working group developing the draft standards specifically for health visiting, so an area of great interest to me. So
thank you, Amanda. And we're also very lucky to have with us this evening Anne Trotter from the NMC. If you could introduce yourself, please, Anne.
Thank you, Jane, and thank you for inviting me to this really important start of the conversation about the draft SCPHN standards. My name's Anne Trotter. I'm the Assistant Director for Education Standards at the Nursing Midwifery Council, and I've been involved in the programme of change at the NMC on all our standards for the last 5+ years, and over the last 18 months working on the SCPHN standards that we're here to talk to you about today. So very pleased to be here.
Thank you, Anne. What we're going to do, Anne's going to do a presentation to put you up to speed where we are, and we want to leave plenty of time for questions and discussion. Obviously you can ask questions in the question and answer, you can put them in the chat. Dave will be our behind the scenes person dealing with all our technical things. Thank you very much, Dave. So without further ado, I'll hand over to Anne. Thank you.
Thank you. Thank you very much. So as Jane mentioned, we've been undertaking a post-registration standards review. Today we're here to talk about the Specialist Community Public Health Nursing Standards that we've been updating, but we've also been looking at the SPQ ones, but we're not speaking about that today. Next slide, please, Dave. So in terms of today, what I'm going to focus on, if I may, and I really want to just quickly walk through these slides in order that we do take time for questions. And I apologise, but the sun has come out after an afternoon of rain and I'm being blinded, but I won't move from the screen. But I want to give an overview on the development of these draft SCPHN standards, and with a particular focus on health visiting and school nursing, but we have also been focusing on occupational health nursing too. There are associated programme standards. So these are education and training standards that will reflect the student journey as people learn to become health visitors and school nurses. Picking out some of the points in relation to both health visiting and school nursing, just so that it can stimulate some of the interest and get a feel for what you might want to focus on. Because mostly what I'm here to do today is to really encourage that discussion and get you all to get so excited and think about doing the consultation once we launch it. We have permission to launch, but we haven't set the date just yet, but more about that later. Next slide, please. So as Jane will recall, as she sits on the steering group, what we set out to do was to develop new standards of proficiency. So that's what people need to know and be able to do in the following fields. So health visiting, occupational health nursing and school nursing, alongside those programme standards. Next slide, please. Now, this is just to give you a flavour of what the NMC does and what everyone else's role is, because obviously the NMC, they don't provide health visiting or school nursing services, nor do they deliver education and training. So the NMC will set those high-level, outcome-focused regulatory standards at a point that can be applied across the United Kingdom, but not necessarily going into significant amount of detail of what needed to be taught. And we will do that with the standards of proficiency, we'll do that for the education and training. But once those standards are finally published, people like Amanda will be responsible for developing the curriculum, and she will be speaking to her partners who deliver health visiting and school nursing services to really get to the nub of what's important in the context of these standards, but also locally for the preparation of those new professionals. And so there'll be much more detail within the curricula than you would see in the NMC standards, where there would be emphasis on the types of content and topics to be covered alongside things that people need to achieve in practice and the ways of how they do that. What we say at the NMC is that the NMC says what needs to be, people need to know and be able to do, not how they will actually learn how to do that. Next slide, please. And we've been co-producing these draft standards over the best part of 2020, and clearly that's all been done under a pandemic setting. So almost all of our activity has been done virtually. We did manage to squeeze in a couple of meetings, did we not, Jane, way back in November 19 and January 20. But we appointed an independent chair for the steering group, that's Dr. David Foster. And we went on to appoint 3 independent chairs for one for each of the fields of SCIF and practice. And they've been helping us in leading on that work. And then we introduced additional groups. So there has been a group of professionals and stakeholders across the UK who contributed to what we're calling the core standards, those standards that apply to all the fields of practice. And then there have been groups that have been focusing primarily on health visiting and focusing primarily on school nursing, for example. But we wanted to bring other expertise in as well. So we set up different groups, one looking at any research or public health agenda research, so that we could really think about not just what people do now, but what they might want to know and be able to do in the future. Prescribing, not necessarily something that everyone agrees on, but we wanted to get a group together to see what that prescribing practice or prescribing scope of practice might look like. And then, as I said before, the education and training standards, we set up a group, and there is an independent chair for that too. Next slide, please. This, if any of you have heard any of the presentations we did last year, this is a slide that we use quite often. And this is just to give you a feel for all the evidence that has gone into these standards. But I just want to pick out a couple. I mentioned the pandemic. We couldn't do this work without thinking about the impacts of what living through that pandemic and what that has meant for health visiting and school nursing services, as well as for families, for communities, and for children and young people. But the orange hexagon really looks at the pre-consultation engagement. So that's what everyone told us over the duration of some almost 40 events. So much so, we were getting such rich data coming out of chat boxes and stakeholder engagements that we asked an independent research company to look at that and to come up with the themes emerging from all those conversations. So we published that on our website last year, and that's available for anyone to take a look at. It runs to almost 130 pages, would you believe? But the commissioned research we did right at the very beginning was looking at the standards we have now. What works, what doesn't, what needs to be better. And that became the foundation for the work that we went on to do. But inevitably, all of this has to work across the United Kingdom. So where Amanda is in Wales, there'll be different policy initiatives, perhaps to those in England, even though they're primarily similar, the way they go about it might be different. So we have to understand what that means in each of the 4 countries. Next slide, please. Again, many of you might have seen this, so I don't want to dwell on this too long, but we asked people, what would the future look like? What's important? Not delving into health visiting or school nursing at this stage, but what's important for specialist community public health nursing? As you know, the protected title in law is specialist community public health nurse. So we started there, and this list that you see in front of you are the types of things that we heard consistently come up. So very much about being autonomous, but with that focus on public health rather than caring for people who might be unwell, even though that's part and parcel of it too. But it's thinking about how to promote health and well-being, how to keep people healthy, and if people do have illness or long-term conditions, then how they can stay as healthy as they can. I'm sure we're going to talk about age and age ranges over the course of this evening, but that notion of being able to look at the life course in relation to their professional practice. So although someone, and I'll use occupational health nursing actually as an example here, though occupational health nursing focuses on people at work, those people at work have private lives too and have families of all ages surrounding them. So it's looking at how work influences home and private life as much as how home and private life influences work. So across the life course is reflected in SCPHN. Very much about, all of last year we've heard about, we've been driven by the data and coming out of the various country lockdowns. We'll be driven by data, not by dates. But this was a theme here. It's very much about knowing what the data is, how to maximize and use that data, but also to recognize the research that still needs to happen because the information, the data, the evidence either isn't there or is inconclusive. Less of an ill health, again, more about health and well-being, health improvement. And again, one of the issues around the pandemic, we all know that health inequalities exist. You only need to think about Marmot to know that. And 10 years later, last February, he said that nothing much had changed in England. But COVID, again, has brought this into sharp focus in terms of health inequality. So these roles are about doing more, not just knowing about it, but what are we doing about it? And then the other things that go with this type of practice, being able to communicate and educate, being leaders in your field, collaborating with others, and being that advisor for safety and quality, because risk assessment, clinical governance, improvement methodologies haven't gone away, they're here to stay. Next slide, please. So then the group started looking at health visiting, and that's where colleagues came into this very strongly in terms of what was important. And that was the fundamental question. What is important, not just for now, but into the future, for the next 10, 15, 20 years. So again, you can see some of the things that shaped the drafting of these standards. Very much not just about being a leader, but also being someone that can do. So part and parcel of that is that relationship they build with people, with families, with communities. But leading the services, not just the ones that they're told to do, but thinking about how to do this differently, recognizing that there's other things that you have to think about, how to be resourceful, how could we be creative, not just tired, thinking about what interventions work and which ones actually need to get better. And it's very much about how all of those children can and families can receive the care that they need, receive the support that they need at a time that they need it, which is ultimately to encourage their ability to manage their own health and well-being. Next slide, please. Further comments around here. Technology came up a lot, not just thinking about there's one size fits all, but how do you tailor it for the different families you have there is no one thing that works. It's what are all the things in a health visitor or school nurse's toolkit? Thinking about the communities at large and what they are facing. And very much around a human rights approach, being able to be fair and equitable, thinking about, again, going back to the inequalities and what needs to change in order to prevent those health inequalities. Next slide, please. So just a thought, if any of you are thinking about questions, there are many, many more, but I've just picked out some. So maternal health and infant mental health comes up repeatedly in our engagement. That continuity of care, now whether that starts from the transition from the midwife to the health visitor, or bringing in all those other services that needs to take place, or even from the health visitor to the school nurse, or whether it's seamless or whether it's joined up, or whether it involves social work, local government, all these other things that are part and parcel of your day-to-day work. Life course is coming up a lot because obviously traditionally there was a very clear years and age parameters, whether from health visiting you look on it as a cradle to grave approach, or whether it's for a school age. Are we talking about 4 years to 18? Are we talking about 5 to 19? Are we talking about sometimes from 5 to 24 years? So thinking about the SCPHN and the life course has become a vital thing. Inevitably, we are a diverse population across the UK. So what does that actually mean? And I've mentioned tackling inequalities, I'm not going there again, but then a whole thing, some people said, hold on a minute, what about safeguarding? We do a lot of safeguarding. So why is that not more prominent in the standards? So again, it was for you to think about, is it prominent enough? How do you manage risk? Should it be emphasized or amplified more? Next slide, please. So then we move on to school nursing. Similar exercise. We asked lots of school nurses what the future vision would be, tested it out, saying whether it was ambitious enough, could we stretch ourselves even further? And clearly this was looking at children and young people, being at the heart of this, being that advocate for that population, but very much on a rights-based approach. Thinking about not just doing to children and young people, but empowering them to think about the choices they either make or might go on to make. Thinking about how the risk-taking behaviour that might be peer pressure driven or individually driven, what is it that means and what impact could that have, not just in the here and now, but subsequently. Resilience sometimes is an overused word, but it's something that came up a lot. Now, whether it's you think it's resilience, whether you think it's resourcefulness, whatever, some of this language becomes really important in our standards as well. So you might want to think about whether we're getting that right. Again, school nurses work with a range of services and people. So it's just thinking about whether there's enough emphasis on that. Very much thinking about prevention and promotion rather than having to do things afterwards. And then the leadership aspect is coming in here. Are these people being prepared to be those future leaders, recognizing that when they become a school nurse or a health visitor for the first time, they're at the start of that career? Next slide, please. So again, just some areas to think about, Jane and Amanda. Mental health and well-being came up a lot, and sometimes people would say, we do more in mental health and well-being for children and young people. And if we think about prescribing practice, then that might be the thing that needs to get lost. So people were seeing trading what's more important sometimes when we listened. Again, thinking about the impact on children and young people when there are inequalities or children are suffering from deprivation. Now that can be in many forms. It could be poverty, it could be food, it could be technology. All of these things come into play. Things around the risk-taking behaviours definitely coming up, thinking about those who are vulnerable. And with safeguarding, looking at the nuance here of the wording about adopting a trauma-informed approach. So again, thinking about that particular age category of SCPHN practitioners. Next slide, please. So we took all of the thinking, all of what people said was important, looked at all of the evidence and tried to translate that into new draft standards. So the standards have been arranged under these 6 headings that you see in front of you. We, in one of our engagement events, we said, do you want to call them domains? Do you want to call them platforms? Do you want to call them something else? And the vote was taken and people wanted it to reflect spheres, as in spheres of influence. So at the moment, they're called, the section headings are called spheres of influence. So you can see the 6 in front of you, all the way from autonomous practice in a public health setting, through to leadership, but not losing sight of working with people and families, be that at the individual base or looking at population health more broadly. But not just being static, thinking about what the future holds, what needs to change and how their roles can help lead and invest in new and different ways of practice. Next slide, please. So you're the very first group to see what the draft standards front cover looks like, because I've had a little bit of branding since Jane received her plain Word copy. So this is a draft of the front cover. The little pictures you see are called doodles. In Future Nurse and Future Midwife, it was the students that helped to pick the design. So there's a suite of design across all our standards now. And this is all being prepared, and Amanda is also being published in Welsh. So there are options for everyone. Next slide, please. So within that, what we've tried to do is also show the organisation of the draft standards. So I mentioned those 6 headings to you. And how did we decide what was a core proficiency? So that means it applies to all the fields of SCPHN practice, and what only applies to health visiting or school nursing. So you can see in sphere A and B, there are no field-specific proficiencies. There are only things that apply to everybody, because the groups felt that those things were important across the 3 different fields of practice. But then in section C, D, E, and F, there are core proficiencies that apply to everyone, and there are also SCPHN field-specific proficiencies. So a health visitor, for example, the student would have to achieve both the core proficiencies for C and the field-specific proficiencies for health visiting. And equally, the school nurse would have to meet for F, for example, in core, but the field-specific for school nursing in F. So we've tried to lay it out within the draft document in a way that we hope is helpful, but we're going to test out the layout as well to hope that that makes sense. Next slide, please. So this is just 2 very quick examples, and I see that Dave has said that the slides will be available. So do take time to look at this afterwards, because I appreciate I'm running through this quite quickly. So just to give you an example between the core and the field specific. Next slide, please. So when we were looking at the sphere under C, so the heading title is Promoting Human Rights and Tackling Inequalities. So the core standard says that SCPHN health visitors, occupational health nurses and school nurses will be able to critically analyse the causes of health inequalities and health inequity and so on. And then you will see the corresponding field-specific standard for each of the fields of practice. So the wording is different in recognition that the 3 scopes of practice are different, that a health visitor is not a school nurse, is not an occupational health nurse. So you can see that focus difference, the nuance difference in relation to the primary field of practice. And then the next slide just gives you another example of this, please, Dave. So this is looking at advancing public health services and promoting healthy places, environments and cultures. So again, you can see the core standard that applies to everyone. So we picked this one out given we're living through a pandemic. So be capable of planning for emergency and pandemic threats to population health, taking account of the direct and wider risks impact and hierarchy of controls on health, wellbeing and service provision. But then moving on from that, there is one specific to health visiting, one for school nursing, and one for occupational health nursing. So you can see, again, you can look at health visiting very much to look at working with parents and carers in relation to children. And then the school nurse is looking at community needs that improve the health and well-being of the school-age population. So that just gives you a sense of where these draft standards have taken us. Next slide, please. So I know there's lots of things that Jane and Amanda and others within CPHVA will be asking questions and thinking about, but thinking about the outcome. So we're focusing on the what, not how you do it. So is there enough of an outcome focused look to these draft standards? Some of our older standards very much focused on processes and inputs. This is an outcome approach to our standards. But then, are we being ambitious enough? And that's the challenge that the discussion groups had all the way through. Is this more of the same? Are we pushing it enough? Not enough? Does it feel right? And digital technology is one of those areas, for example. And do they reflect what you would expect health visitors and school nurses to know and be able to do? Not just today. So it's not preparing from what happens now today, but what might need to happen in the future. Next slide, please. So just let me give you a little bit and then I'll stop on relation to the education and training standards. So these are standards for post-registration programs. Next slide, please. So again, you get the very first look of the front cover. Now they're badged as standards for post-registration education programs. We do need to look at these in the context. You can see the Part 3 reference. So the Part 1 reference is our education framework, which we've already published, and the Part 2 is standards for student supervision and assessment. So Part 3 is very much about the education and training program, the curricula that the universities and their practice partners will develop. And this document contains the standards for both SCPHN and SPQ programs, in recognition that there may be things that shared learning takes place, but there are other times when things have to be different. Next slide, please. So these draft standards are laid out in the way that the other program standards are, so very much focusing on the journey of the SCPHN student. So the first category is around selection, admission and progression, the curriculum itself, practice learning, supervision and assessment, and the qualification to be awarded. And that's standard with all the program standards we've published so far. So future nurse, future midwife, non-medical prescribing and nursing associate in England. Next slide, please. So again, though, we know that there are times that SCPHN needs to be different to the SPQ. So even though there are potential for shared learning, there is also the need to recognise the unique differences between the two programs. So there will be standards we see that apply to both programs, but there will be those standards that only apply to SCPHN programs, and there will be those standards that only apply to SPQ programs. Next slide, please. So again, thinking about the admission criteria. So what I mean here is, historically, there have been standards that say you have to have been qualified for 1 year, 2 years, 3 years, pick a number before you're eligible to learn to be a health visitor or a school nurse. And as you know, that's changed from time to time along the history. So instead of thinking of an input measure, what would an outcome measure look like? And so the standards are focusing there. But also whether, as we know, SCPHN is open to both registered nurses and midwives, just making sure that all of those things are as they should be. We don't state the content, I mentioned that, so we wouldn't say there needs to be 20 hours of genomics or 50 hours of safeguarding. The content would need to be determined as part of the curricular design. But some people say, no, the NMC should state what needs to be taught. And then we've had a long conversation about consolidated practice. So now there is an emphasis on the consolidated practice towards the end of a SCPHN programme, and the NMC plays their part in making that emphasis through its standards. Now we're saying, if you want to have consolidated practice, have it, but do you need the regulator to set that time limit? Supervision and assessment, I'm quite sure there'll be lots of questions about this because the standards for student supervision and assessment have already been published. So again, what we've tried to do here is go a little bit further in what we mean by that in the context of the SCPHN programme. And then the last one, lots of debate, what should the level of the award be, the qualification? So many people think we should keep it open, allowed widening access and participation, and others say absolutely not, it can only be at master's level, because these are practitioners who'll be working at the top of their license to practice. And it might even be advanced practice, so it needs to be at master's level. So again, what do you think about when you think about these things? Next slide, please. And this is my last slide. So what are we doing? We're producing all these materials, getting ready for the consultation. So there is a consultation document for professionals who will be responding and for members of the public. And that's just giving an overview of what this work is all about, as well as publishing the draft standards. There will be a set of surveys, one for professionals, not just nurses, midwives and SCPHN, but also other health and care professionals will be invited to participate. There'll be a version for members of the public. There'll be an easy read version for people with learning disabilities or difficulties, and they will also be translated into Welsh. And we will not be hosting the survey. It will be an independent research company that will be doing that. We do not mark our own homework. It will be entirely independent. At the same time, there'll be a qualitative aspect to the consultation. So the independent research company will be doing in-depth interviews, focus group discussions, telephone interviews with members of the public and seldom heard groups, so that we can make sure that we capture what they need from health visitors and school nurses. We are doing some user testing as well, and that's looking at the documents, not so much for the content, but whether we are being inclusive, we're being accessible, we're being measurable, and we're being accessible in relation to those standards. And that too will be undertaken independently. And then as we're gearing up for the launch date of the consultation, which we think might be after Easter, there will be some, we're thinking about, well, what will that communication look like? Because we recognise that most of that will be happening virtually again. And we are certainly gearing up our independent chairs to come with us on that journey so that they can be part and parcel of that discussion. But what we really want to do once we launch the consultation is encourage people to take part and have their say. So I think that's me, Jane and Amanda. So over to you. Thank you.
Thank you, Anne. That's really helpful. And as you say, there's an awful lot in there. So, I mean, there's lots I could say, but I think, you know, we've had quite a lot of questions, so it's only fair to move on to those, I think. I had some through email. I think there was a theme there, so I'll kind of put that one together. And that was around, you know, that SCPHNs who you know, well, nurses or midwife, well, more nurses who complete the course come from various backgrounds, so possibly haven't been exposed to breastfeeding. So there's questions around whether breastfeeding, infant feeding will be a key component, whether the UNICEF BFI breastfeeding standards will be incorporated into the standards. I think I probably know what you're going to say, but I'm going to leave that to you to say. Thank you.
Thank you. What I can honestly say is that infant feeding and children, the nutritional needs of children is definitely there. We had the same conversation actually about the baby-friendly standards in our future midwife review. And one of the challenges of incorporating someone else's is that if we put the baby-friendly standards into our regulatory standards, if a university doesn't have baby-friendly status, then we could not approve the programme. So we tend to mirror the things that are there rather than be specific about another accreditation, for example. So in the Future Midwife, we actually had someone from UNICEF working closely with us to see whether there was enough there that it could be mapped across to the baby-friendly standards and therefore to any accreditation that either the health visiting service wanted to achieve themselves in terms of their provision, or the university in reaching that accreditation status. So they're not there word for word, but infant feeding is there. I think what will be really helpful for people who do the consultation is if you think there's enough information in our standards to reflect that important aspect of practice.
Brilliant, thank you, Anne. And what I'll say is, if for email questions, I have shared them with Anne, so actually we could provide a response via email if we don't get round to them, because we have got a lot of questions. One is, will the new standards be aligned with the apprenticeship standards?
Apologies, it's a bit chicken and egg. What we do is we would publish our standards, and then the Institute for Apprenticeship and the Trailblazer Group would have to develop the apprenticeship standards that meet our new future standards. And then we would approve an apprenticeship route. So it kind of works that way. So anyone who has an apprenticeship route at the moment will be against the existing standards. So there would need to be an apprenticeship route that has been mapped to the new NMC standards once they go on to be finalised and agreed. But it's possible, it's entirely possible.
Yeah. Thank you. Another one, which again, I don't think you'll be surprised at. You and I have certainly had lots of conversations around this. And it's a trust that's using the updated supervision and assessor guidelines to deband the practice teachers from a 7 to a 6. Obviously, this isn't the NMC's role around pay, but they're asking whether it was the NMC's intention to do away with the practice teacher role, and will the new standards reflect the need for experienced practice teachers, or whether we call them assessors, whatever we call them.
Yeah. So the standards for student supervision and assessment replace the old standards to support learning and assessment in practice. So the SLAP standards, as they're commonly known, where this practice teacher standard was embedded. So that means that the NMC no longer approves mentor, sign-off mentor, practice teacher, or teacher qualification programs. So that is no longer there. But that doesn't mean that people who are going on to be practice supervisors, practice assessors, or academic assessors for SCPHN students haven't been suitably prepared or capable of demonstrating that they have the expertise to carry out that role. So that's in the actual supervision assessment standards now. There's an expectation that they should be suitably prepared and they should be supported to fulfill the role of supervisor or assessor. That's now, we're not consulting on that, but the programme standards have a separate section on supervision and assessment. So we are able to say a little bit more, so that there's recognition that someone who is brand new to being a health visitor or school nurse, for example, the employer can't just assume that because they were a supervisor or assessor for midwifery or for nursing, that they automatically can be an assessor or supervisor for SCPHN students. So again, we want people to look very closely at that and see whether we've got the balance right. And you're right, in some ways I'm very pleased that the NMC's got nothing to do with the money side of things.
Yeah.
Yeah,
I think it's difficult because some of the questions do relate to that. So it's they relate to the way services are commissioned, and the fact that because infant mental health and issues around attachment are so important, health visitors in reality are finding it difficult to build the trust that enables them to deal with that within the 5 mandated visits in England. That's a really difficult one, but can the standards have any impact on things like that, Anne?
Oh, definitely. Now, what we wouldn't do is put a number on it. So we wouldn't say there needed to be a minimum of 5 visits to establish that relationship, or more number of visits. But what we would say is that they are capable of, and they know how to, and they have demonstrated that they're proficient in being able to build those relationships, to have those conversations about infant feeding or attachment or any wider mental health related matters. Our standards absolutely are clear on that, because we recognise that that is so important. Now, we know that the 4 countries, their provision might operationalise the amount of time a health visitor goes into the home, for example, but we would say that it's not about the time, it's about what they're able to do when they are in the home. And that's why we've worked closely with the 4 countries as well and their representatives, so that we can get this absolutely clear, because our standards have to land properly in all cases.
It was an interesting one that came from Marie, who's in Scotland. Hi, Marie, thanks for the question. That the context there is that it's a highly prescribed role. So she was wondering whether the word autonomy is actually still relevant to practice when you're working in, quite a prescribed model.
Yeah, that's Marie, thank you. That is such a good question. And only last week someone was not arguing with me, but putting the point across to say, well, no one today is truly autonomous, because we all do work in collaboration with our teams and within our services. But I think the model that you have in Scotland is not necessarily the model that's reflected everywhere, but that's why we had to make sure that the model was applicable for each of the 4 countries, but also the fact that our new standards could be the catalyst for change, to show how much more health visitors and school nurses can make a difference to the populations they serve, rather than perhaps through some of the prescribed ways of working as you're identifying. But that's not to say if a country wanted to do that they couldn't do that. But what we're also trying to do is get, that's back to the ambition. What is it that these people can do that actually would make such a big difference to families, to children, to young people?
Thank you. Sorry, we are trying to rush through them, Anne, but we have got a lot of questions. I hope you're okay if we carry on just a little bit after quarter to. So a question from Karen. Really good that you're joining us, Karen. I know Karen well. And she's saying in her area, prescribing practice has been removed because they actually work in the local authority. So will prescribing practice be encouraged across all sectors? How do we kind of, make them relevant to all?
Prescribing actually took a massive steer as part of our engagement. It became one of those big topical areas at one point in our pre-consultation engagement activity. And what we see is lots of diversity around. Now, I mentioned at the beginning about people telling us that people who are in SCPHN roles are actually working at an advanced practice level. And one of the things that we've committed to do, we haven't done it yet, but this work is a bridge towards that, is that we have committed in our strategy to see whether the regulation of advanced practice is needed. And for many people, advanced practice includes a prescribing scope of practice too. So I would say we probably received every view imaginable about it should be V100, so being able to prescribe from a community formulary, or it could be full independent supplementary prescribing. Other people said, no, it's a biopsychosocial model. If we go into prescribing, then we become a medical model profession. Other people telling us, as you've described, it's been taken. Some people described it, our prescription pads have been taken away I am a prescriber, but I'm not allowed to prescribe anymore. So we heard all those types of scenarios put to us. So the NMC has to come up with a position and then test that position. So at the moment, we have put prescribing into the draft standards, and we're testing whether that should be mandatory. So everybody has to complete a prescribing program if they do a SCPHN program. And if it's mandatory, which is it V300, is it V100, or whether it should be optional, or whether it shouldn't be there at all. Because we didn't reach consensus on this point, Jane. And I think some of this is about not just what happens today, what could the future look like, and what would, not necessarily just thinking about what it will bring to the professionals, but what would it mean to the children, to the families, to the young people, if SCPHN practitioners were prescribers. And I mentioned earlier about people saying, well, you know, it's already packed curriculum. If you put prescribing in, then what are you taking out? So all of that's been at play, but at the moment it's in, and we're testing whether that's right.
Yeah, and a very good point that somebody's made further down. I'm trying to keep on top of all these questions about whether commissioners, particularly, well, in England, because it's England that's got commissioners, whether they've been involved in standard development. I think there's a feeling that, you know, often they don't understand the service and actually what health visitors and school nurses could do. Another one around
we did involve them, just quickly to say, I'm not saying we spoke to every single one, but we had a roundtable event for employers and for commissioners, so we were able to elicit some views, because obviously commissioners are not everywhere, as you know, so we included employers in that, and again, real mixed picture about what people thought was needed.
Another one around whether the principles of health visiting are visible within the specific field criteria.
Now, if Jane Harris was here with me, now Jane Harris is the independent chair for health visiting, and she is herself a health visitor. And we had what we called a challenge session, and where I was challenging Jane and the team on the standards. And she vividly remembers me, because one of the things I asked her was, does this scream health visiting to you? Because if it doesn't, do we have a problem? So that's one of the things that we gave ourselves in a challenge session. But what we now need to ask ourselves more widely of the audience that are listening today is, do you agree? Or is there more that we need to do?
Brilliant. Another one around when approximately you envisage the new standards coming in, because obviously HEIs need to plan.
Yeah. Now, this is an interesting one, and some of you may have seen the press over the weekend from the Nursing Times. So I mentioned at the beginning, we're developing the SCPHN standards, and we're also developing the specialist practice qualification and community nursing standards. So things like health visiting, district nursing, general practice nursing, children's community nursing, community mental health, and community learning disabilities nursing. Now, when we speak to people who are in the SCPHN community of practice, they want us to just get on and do the consultation. The same is not true for the other group. They say that it's too soon, there are too many competing priorities, and they're not always keen that the standards have got to the right place. So we've got two different sets of views, but if we go ahead after Easter and think about genuinely launching this consultation, we will launch the consultation for 16 weeks, not 12 as is normal, to take into account that people have other priorities, or they may even be trying to get some leave as we look to the future and perhaps people easing out of lockdown. So the consultation will run for 16 weeks. We will then have a whole bunch of work to do to look at that feedback, see what needs to change, what needs to be included that's not there, and so on. But what we would like to do, if we start soon after Easter, is complete the standards by the end of this calendar year. And then there'll be a transition period for universities to develop their curriculum and seek approval against their new programmes.
Brilliant. Just to say, Dave has been recording all of the questions, so because we have still got a lot to go, we won't get through them all, but we will, you know, we'll build them into our next event. So we've got 2 more events coming up.
Perfect.
And on the 22nd of April and the 18th of May. So I think there is one I would like. We've got a student on. Hi, Dan. He's a Skiffon student. He's really struggling trying to access alternative practice, especially during the pandemic. So he's asking whether there's any leniency, because he doesn't want to not pass the course because he can't access it. So yeah, that might be one you might want to take offline, but it's important we address it.
To get in touch directly, but hopefully he's also been talking to his university about what possible options are to enable him to complete in time, because there is some flexibility there, I'm sure.
Brilliant. Amanda, shall I go over to you to see if there's anything?
I mean, lovely. Thanks, Anne. Yes, just picking up on that point, very interesting point by Dan. And you're absolutely right. And, you know, we work very closely with our practice partners who are very creative and very resourceful, as you've already spoken about, in enabling, you know, practice to continue in such wonderful ways and continue to support our students. So please speak with your university, Dan, and we'll support you, and you're welcome to also get in touch with us as well if you'd like to discuss that further. And I think it was very interesting, that whole presentation. Thank you very much. You know, you've gone further on now in terms of what we began to explore and where we were with the draft. I think your points in relation to what everyone needs to think about when it comes to this consultation phase are very, very important, and you call them thinking points. And I think that obviously everyone has their own ideas and views and specific areas of thought, but I think those thinking points are really, really interesting to help guide us in responding to that consultation. So I'm imagining that those points that you raise will be used for us to feed back on, particularly, you know, around the outcomes, around the focus, and how it is ambitious enough or isn't. So you know, we're really hoping that we can stimulate awareness. One of the principles of health visiting, we are stimulating awareness now with all of our colleagues across the UK, and I really hope that everyone takes this opportunity to engage in this process. It is so important that everyone has their voices heard, their views and opinions considered, because this needs to be right for the future. The last standards, obviously 2004, we've been waiting so long for this to happen. So we're at such an exciting point, and as you know, we've been lobbying you know, for this to go ahead now without any further delay, hopefully. And I know all of my colleagues in Wales are with me on this, and also across the UK within the CPHVA. So I do hope that after Easter we are able to feed back on this. And Jane, you actually covered all the other questions that I had from emails that I've received. Those things were picked up on. So thank you very much.
Lovely. And I know we didn't get round to all of the questions, apologies, but we have got them noted down, so they are themes that we will pick up in the next one. There will be an evaluation coming out, so what we want to do is get your thoughts on how we can run the webinars so that you get the most out of it, and you know, if we need Anne or a representative from the NMC at the next one, they're very happy to do that. But equally, you know, if we want conversations among members, then you know, we're here to do whatever works for you.
We're very happy to support you in any way we can, but we also realise that as CPHVE, you might want to have private conversations about, well, you know, we're not sure that goes further without the NMC there, because when we move into the full consultation, the way I describe it is I become Switzerland. So I don't defend anything. I don't say, oh, you've no idea how much blood, sweat and tears standard 6 took us to get to the right words. I step back, and it's all about you telling us whether we've got it right. And if we haven't got it right, what would make it better? It's not just about, no, this wouldn't work, but tell us what would make it better. Because these standards, they're not the finished article, that we've got to a good enough place where we can go out to wider consultation. But as I said, after the consultation, we will put all of it back under a new spotlight. And only this morning I was sent another evidence report about some of the impacts of COVID on the services relating to the standards that we're looking at. So that's new evidence that didn't inform the drafting. So all of that goes into the pot as well once the consultation is closed. But it's lovely to get so many questions. It's great that people, I agree with you, the standards are old. We should have done it many years ago, but we're doing it now. And that's what's really important.
Absolutely, absolutely, really important, really important. So, Anne, we're going to draw this session to an end, and thank you for everyone who's joined us. Thank you, Anne, for your time. We very much appreciate that, and we hope that you may be able to join us again if needed. I know that you're happy to do that. Jane, thanks very much for taking all those questions and helping some of those who joined us today to have some answers. I know that there are still many questions, but very exciting next phase. So we're looking forward to that, and we're looking forward to you all joining us again at our next webinars. Thank you.
And thank you.
Thank you very much.
Have a good evening, everybody.
Have a good evening.
Thank you, everyone.
Bye.
Thank you for your time. Bye.
Bye.
Bye-bye.